Implantation of the blastocyst is completed during the second week of development. As this process takes place, the embryoblast forms a bilaminar embryonic disc. This embryonic disc will give rise to the germ layers that form all the tissues and organs of the embryo. A small cavity appears in the embryoblast, which is the primordium of the amniotic cavity. Now, amniogenic or amnion-forming cells, called amnioblasts, separate from the epiblast and organize to form a thin membrane, the amnion, which encloses the amniotic cavity. The epiblast forms on the floor of this amniotic cavity and is continuous peripherally with the amnion. The other side of the bilaminar disc is the hypoblast, and cells from the hypoblast migrate out to form the extra-embryonic lining of the umbilical vessel or the yolk sac. The outer layer of cells from the umbilical vessels, the endoderm, forms a layer of loosely arranged connective tissue, the extra-embryonic mesoderm. While this is happening with the embryoblast, the trophoblast is also changing. The syncytial trophoblast continues to invade the endometrium, and blood from the ruptured maternal uterine capillaries are eroded with some glandular cellular debris, and they form these fluid-filled lacunae that is the start of uteroplacental circulation. Nutrition passes to the embryo by simple diffusion. Oxygenated blood passes to the lacunae from the spiral endometrial arteries, and deoxygenated blood is removed via the endometrial veins. By day 10 or 12, thereabouts, of the embryo, it is completely embedded in the endometrium. The lacunar spaces form lacunar networks with sinusoid vessels starting the intervillous processes of the placenta. Is growing much faster, starting the intervillous processes of the placenta.
Probably.
The trophoblast is growing much faster than the embryoblast at this stage. The extraembryonic mesoderm also begins to increase, and they have isolated extraembryonic colymic spaces that appear within it. And eventually, these spaces fuse to form a large isolated cavity, and this is called the extraembryonic coleum. This fluid-filled cavity surrounds the amnion and the umbilical vesicle, except where they are attached to the chorion by the connecting stalk. As the extraembryonic coleum forms, the primary umbilical vesicle decreases in size, and a smaller secondary umbilical vesicle forms. This extraembryonic coleum splits the extraembryonic mesoderm into two layers. The extraembryonic somatic mesoderm, which lines the trophoblast and covers the amnion, and the extraembryonic splanchnic mesoderm, which surrounds the actual umbilical vesicle. This extraembryonic somatic mesoderm and the two layers of the trophoblast, as you can see here, forms the chorion and the wall of what is now the emerging chorionic cavity. Proliferation of the cytotrophoblastic cells produces cellular extensions that grow into the overlaying syncytial trophoblast. The cellular projections from the primary chorionic villi are the first stages of the development of the chorionic villi of the placenta. Blastocytes typically implant into the body of the uterus, usually on the posterior wall, less often on the anterior wall, and they could be detected by ultrasound sometimes as early as the end of the second week. Now, in some cases, the blastocyte doesn't make it to the uterus and instead gets embedded in the uterine tube. This is known as an ectopic pregnancy, and it's usually associated with factors that impede the transportation of the blastocyte to the uterus. You might think, so what if the embryo is embedded in the uterine tube instead of the uterus? Well, as the pregnancy progresses, the growing fetus will impinge and eventually rupture that tube, and you'll have bleeding into the peritoneal cavity. In many cases, the patient will present with signs of pregnancy, including a positive pregnancy test, right, which is looking for beta-HCG in the urine or the blood, and abdominal pain due to distension of that uterine tube. This pain can actually easily be confused with appendicitis, especially when a woman does not yet realize that she's pregnant, because it can cause a similar irritation of that pelvic peritoneum. So pregnancy and nothing in the uterus means it's somewhere else. Think ectopic. And also remember, appendicitis doesn't cause bleeding from the vagina. So always consider ectopic pregnancy in a woman of childbearing age with abdominal pain, peritoneal irritation, and vaginal bleeding. Now, implantation is inhibited by both progestins or antiprogestins, the morning after pill, if you will, taken after unprotected sexual intercourse. Now, it's actually intended to prevent ovulation itself, but if ovulation has already occurred, it will prevent implantation. Intrauterine devices, or IUDs, are also able to interfere with implantation. If you're ever in a bind, just remember two things. Implantation is completed in week 2, and the embryo is a bilaminar layer.